save 2 hours of your time? And the women answered, those 2 hours that we walk to the next village is the best part of our lives every day. Those are the only 2 hours we could get away from our husbands. How dare you take those 2 hours away from us? And the lesson learned here is that sometimes we think what is best for the rest of the world and we design solutions to address them. We never consult the people that we are trying to help. We bring them in at the end of a design thinking process. We bring them in when we're ready to deploy without asking them, is this what you need? Is this what you want? So how do we move forward given the issues of data bias that I have explained to you? We see only one path to forge for AI to benefit everyone and not just those who are privileged. And this path has two requirements. The first is regulatory guardrails, not voluntary self-regulation as suggested by the White House, but policies and incentive structures that result from continuous open dialogue and which engages communities that are disproportionately burdened by disease. You must have heard that the EU AI Act, at least a draft version of it, was released about a couple of months ago. And it bans intrusive and discriminatory uses of AI systems with strict penalties. However, it is not clear who will be punished, those who develop such systems or those who use them. These are some of the components of the EU AI Act. There is a requirement for a data card that would describe very quickly the composition of the training and the validation cohort. There's also a model card that describes the analytics pipeline. And this will be required now for any AI model that will be deployed, whether it's in healthcare, it's in transportation, and it's in education. And a group looked at whether the large language models that are available now, how do they stack up against the requirements of the EU AI Act? And it doesn't look very good. Most of them would have failed and would have been fined as a result of not complying with the requirements of the EU AI Act. And then in addition to transparency on how AI models are developed by providing a data card and a model card, we are also proposing public reporting by anyone that collects health and wellness data to disclose who are they selling their data to. And we think that this should also be required for any AI models that are being developed. Who are these models being sold to? And there is some precedent for this public disclosure. For example, among physicians in the United States, we have the Sunshine Act where we are supposed to report any interaction with industry, and those are all found in a website. And we think that this should also be the case. We need to know who Apple is selling their heart rate or their wearable data to. And we need to also know who they are selling any models that they develop. The second requirement of the path forward to make sure that AI benefits everyone is an expansive dialogue about the methods and stakeholders involved, emphasizing the how and the who of AI over the what. The most important question is who are sitting at the table and charting the course of artificial intelligence. Investments should be channeled towards building transparent, accountable, and inclusive pipelines for artificial intelligence for their development and their deployment. At present, billions of dollars are poured into data sets, computational resources, and environments. The machine learning community is preoccupied with what models to build and what benchmarks to evaluate against. But unless we prioritize the who are developing and deploying AI, and the how, is there transparency and accountability for responsible AI, the tens of billions of dollars are all for naught. If AI hopes to address the diverse health needs globally, then the AI research agenda should be developed with stakeholders who represent those who are burdened by diseases and disasters. Historically, the medical knowledge system is inordinately generated and operated by a relatively small group of academic investigators from top-tier research institutions in rich countries. We published this paper in 2012 22, I believe, looking at which countries are contributing data sets to develop and validate AI models. And not surprisingly, almost half of the data comes from the United States. Most of the world are bystanders in the AI revolution. The biggest contribution, I believe, of AI is shining a spotlight on the data that fuels the medical knowledge system, the medical knowledge that informs our understanding of health and disease, and the medical knowledge system that dictates how we prevent, diagnose, and treat diseases and injuries. As the AI revolution unfolds, there is increasing scrutiny of the medical knowledge system. And this is the system which provides the data input for large foundation models. And our group has been looking to answer such as questions as, where does the research informing clinical guidelines come from? How representative are cohorts used to train AI models? Who are given the platform to impact health research? Which groups are being funded? And can we measure and track the knowledge landscape? There are a handful of stakeholders who are in control of the medical knowledge system. These are the stakeholders who determine what research is conducted. And this refers to the funders, including government agencies such as the National Institute of Health, foundations, as well as industry. The second stakeholders would be those who have a platform to conduct research. These are the universities, these are the companies, the startups. And finally, those who disseminate research. They play a huge role in determining which is science and which is not. And these are the journals, these are the publishers, and this is the media. The gatekeepers of the medical knowledge system have enabled a research agenda where 80% of studies are performed in 20% of countries worldwide. This has resulted in a world where translating research findings from one majoritized cohort into general clinical guidelines proves ineffective or even harmful to the rest of the world who are excluded from the knowledge economy. We need to revamp the incentives that perpetuate the structures that preserve the knowledge imbalance. Diversity, equity, and inclusion must be at the core of how research and its investigators are evaluated for funding. Diversity, equity, and inclusion must be at the core of how journal impact is measured. On that note, we introduce the concept of a diversity factor for journals. Given that journals play a huge role in the creation and dissemination of knowledge, it is time to downgrade the importance of the impact factor, a measure of how often papers in that journal are being cited. The impact factor feeds into a market of lemons where the rich, who controls the knowledge economy, gets richer. We know that the lack of diversity among those who create knowledge contributes to a research agenda that fuels health disparities. Isn't it time to make journals accountable for enabling this lack of diversity? Diversity, equity, and inclusion must be at the core of how students and faculty are graded and evaluated for promotion, respectively. It is time to incentivize students and investigators to work in multidisciplinary teams. It is time to replace traditional metrics such as the number of publications and the number of citations with measures of their contribution to promoting collaboration, data sharing, and sharing of other types of resources such as open source software. The knowledge landscape needs to safeguard against the perpetuation of biases and disparities, particularly given the emergence of large foundation models, and we are looking for partners who share that vision. How do we avert an AI-legitimized and AI-enabled further marginalization of those who are already disproportionately burdened by disease? There was a viral video that showed a men's basketball game interrupted because of a tangled net back in May. And the men tried to untangle the net, but no one could. They were trying to out-jump each other. But in the end, they said, we're gonna stop the game because we cannot play with an entangled net. So they left the court. In comes the women's cheerleading team. Very quickly, they form a pyramid, and very quickly, they solve the problem. There are 3 lessons from the story. First is that competition sometimes kills collaboration, which is key to solving complex problems. The men are all trying to out-jump each other in order to fix the net. In health AI, we often hear, my data is bigger than yours. My model is deeper than yours. Second lesson, we cannot solve problems when we only work with people with the same expertise and perspectives as ours. And finally, the third lesson, The problems cannot be solved by the same group of people who created them in the first place, or the same group of people who have allowed them to persist. To avert the disaster from artificial intelligence, we need to diversify those sitting at the table. We need to diversify those who are developing and deploying AI. Fair AI models will not come from privileged individuals like us. And finally, we've heard this saying over and over again, a system is perfectly designed to get the results that it gets. The way we deliver care is informed by a knowledge system that is perfectly designed to produce health disparities. The way we are building AI models is perfectly designed to perpetuate stereotypes and structural inequities. But what exactly are we referring to when we say system? A system is not just the data infrastructure or the organizational chart or a compendium of policies. A system is the unwritten set of rules that dictates how we think, how we learn, how we solve problems, and most importantly, how we work together. And with that, I'm going to pass it on to the next speaker. Thank you very much.
Thank you so much, Dr. Celi. That's very powerful. I'm going to share my screen again and give a brief introduction of Dr. Ng. So bear with me for a second. Okay, so can everyone see my screen? Good, thank you, Dr. Ng. So let's welcome our next speaker, Dr. Raymond Ng. Dr. Ng is a Canada Research Chair on Data Science and Analytics. He's also the founding director of the UBC Data Science Institute and an elected fellow of the Royal Society of Canada. Dr. Ng's main research area for the past 3 decades is on data mining, with a specific focus on health informatics and text mining. He has published over 250 peer-reviewed publications on data clustering, outlier detection, online analytical processing, health informatics, and text mining. So today, Dr. Ng will illuminate us through discussing how to leverage the groundbreaking pre-trained language model like ChatGPT to develop tools for automated table extraction from various types of documents, with application ranging from cancer registry reporting, cancer care, to psychiatry hospitalization. So Dr. Ng, the floor is all yours now. I'm gonna stop share.
Let me share screen. So first of all, thank you for inviting me. It is great opportunity to talk to people in the BC Children Research Institute and the Women Health. So before I go off and give you all some overview of what me and my team have been doing in the past few years about on natural language processing, and I like to just give a little bit of a high level perspective, relative to what Leo has just talked to you about. His talk is very much on the broad level of AI and how we should be really very careful in applying it, developing it, and using it. Now, this talk is not specifically about AI. Natural language processing is primarily focusing in on text data. There's strong overlap because a lot of the natural language processing tools are relying on AI, and in fact, a lot of the issues that we see in analyzing human language is also fueling the development of AI and machine learning. So there is strong overlap. But what is also very specific about my talk is that we are using the language models, and I will talk about that in one slide later on. Not so much in the ChatGPT way in terms of generative AI. We are not actually using the language model to generate anything. We are actually using the language model to extract things for us. And so I want to give that particular overview so that then then I could start. So what are we extracting? So why am I talking about NLP to you all? At this time is your lunch hour, so obviously thank you for coming. And I want to make this talk a little bit, higher level as well. And the first reason why I want to talk to you about NLP is that there's really a lot of unstructured data in health. And particular in my talk, I will cover two broad sources of text data. One is what I call official clinical documents, like medical reports, lab reports. And then the other kind is what we call in the field, in the NLP community, user-generated content, what we call UGC. And so these are blogs, test messages that's actually generated by the users, and the users in this case may be the patients themselves, the caretakers, the families of the patient. And nowadays when you hear about the application of machine learning in healthcare, the applications are predominantly based on structured data applied in electronic health records, insurance data. Some of the applications that I think Leo alluded to earlier in his talk. But I think one of the take-home messages I would hopefully be able to leave you with is that there's really huge opportunity to use and to take advantage of this unstructured data that will allow us to provide better patient care. So I'm going to use a very simple journey of what happened in cancer care. And I happen to over the years I've actually worked on cancer for over 20 years, and now even more so at the level of providing better patient care. So when there's a patient and they may be suspected of having some form of malignancy, they will undergo a diagnostic phase. They will be doing all kinds of tests, all kinds of biopsies. There may be operations. In every one of these procedures, a report is generated. So there's a biopsy, there's a pathology report, there's a surgical report. And then if unfortunately the person has been diagnosed with cancer, then it will be going to the treatment phase, and then there will be rounds of chemotherapy, maybe even rounds of radiation, and again every single step there is a report. And let's say that this person is in terms of the cancer care, it has been successful, but that's not the end of the story, because post remission there will also be any monitoring. And in fact, we do a lot of work. One of our most active projects is, in fact, to identify relapses. And talking about women's health, one of the big projects that we have is to identify relapses in breast cancer, for example. So in this cartoon, what I'm really trying to say is that for the journey of a patient, maybe over a decade, maybe even over 10 15 years, every single step, there's so many clinical documents that get generated. And the clinical documents right now, the current practice is that the clinical documents are very siloed, and they're really rarely linked together. And oftentimes the clinical documents are used to make very local decisions, the decision for the next step. And these key findings over the whole journey are typically not consolidated holistically. So for example, when we think about relapses, we might actually realize that the pathology report 10 years ago is already saying something that is important, for the relapse. And so right now, we don't actually have a lot of tools that allow us to link and be able to manage and deal with the content of this, clinical documents written by, well-trained professionals. The other problem is they're talking about well-trained professionals, and the documents are read, interpreted only by humans. As we know, with an aging population, lack of healthcare resources is really putting a very high demand, and there's significant time delay. Some of these documents may not be read by many in many months. So our ongoing work, and this is to tell you, one program that we have that we've been doing it for a number of years now, is how we could use natural language processing tools filtered with machine learning to automatically extract what clinicians would call fields of interest from clinical documents. So it's this fields of interest, and I'm going to give you a concrete example later. After we extract them, we might be able to use the extracted fields to improve detection of reportable cancer, identifying diagnostic groups, predicting treatment responses, and maybe stratifying risk for relapses. So let me give you a specific example. This is a breast cancer surgical report. And in this report, it's written in free-form text, different points. And what it does is that it talks about, whether there is carcinoma, cancer or not, what is the staging, for example, the Nottingham score, whether there is any lymphovascular invasion, the size, and where it is, the blue anterior margin, and so it is a report like that. And what we want to do is to be able to use NLP so that we could extract all these important fields of interest for future decisions, to be made, or future analysis. The other thing that I want to point out is the negation here. So this is a simple example of a negation where it is showing that you cannot, for some of these reports, you cannot just do a search, because the way that humans express a negation, in this case, is very simple. It actually said no lymphovascular invasion. But somebody could be writing, well, we investigate lymphovascular invasion and there is no evidence that lymphovascular, that LVI, actually exists. So I'm just saying that, in natural language, people express the same result, the same outcome, the same concept in many different ways. And that's why it's not so easy. So the goal is to be able to take pathology reports or surgical reports of this kind, extract from the reports the things that we are interested in, like whether there's invasive carcinoma, what's the histology, and many fields of interest like that. So that is actually something that we have been working on for a number of years, and the success rate is actually very high. And I think it's actually getting to a stage that we might be actually deploying some of the technology. Now, I want to, in the interest of time, I want to change a little bit of the focus. I mentioned to you that they're clinical documents, but what about user-generated content? So clinical documents were written by clinicians, healthcare professionals. This is one important part of the input when we are thinking about decisions to be made. But what about listening to the patients, the families, and the caregivers in terms of their opinions, their experiences, their needs, their feelings, their mood? All those things are extremely important as part of care. And so maybe I could say that in general, actually from a linguistic perspective, from an extraction perspective, from a computational linguistic perspective, user-generated content is actually harder than clinical documents when it comes to extracting from them, because the people who are writing the text could have very diverse background, very diverse writing styles, use of words, length. They may not even be grammatically correct, very, very subjective. You won't necessarily see subjective comments in a clinical document. And then, and there's so many different genres, forums, chat, conversations, and whatnot. So analyzing what user-generated content and use it for healthcare, it's a very interesting, very important problem. Now, how do we do that? Because it is so diverse and it is not so easy. So this is where we bring back pre-trained language model. And so this is the second time that I come back to this question. Why are we talking about NLP? Well, the second answer is that we actually have great advances in pre-trained language model. Now, that doesn't mean that I'm not invalidating what Leo say about what he said about ChatGPT. And in fact, in our work, we don't use ChatGPT because of all the problems that now we know. And the idea of that, so in fact, we use BERT, and which was actually the kind of very, very old version of a large language model, and it was created by Google, barely 4 years ago. And one of the things that I emphasize is that we are using it not for generation, we are using it for natural language understanding, and so that was how we are trying to apply it to, I want to show you a graphics. Some of you may have seen this before. What this graphic said, it started from 2018 and now it's 2023, is the evolutionary tree of the different language models. And so BERT is right here. So it was around 2019 on this branch. And move on to this side, you have, where could I find ChatGPT? So ChatGPT is here. Llama, some of you, I'm sure, have heard of, and maybe have also used Bard. And so, this technology is changing very, very, very quickly. Some are open source, some are closed source. And there's obviously a lot of the issues that I think Leo's talk alluded to. And but, my point is that this is a rapidly advancing area, and so we are trying to take advantage of it in understanding, in our case, listening to the patient. So we focus on 4 things that we want to do. First of all, what are patients talking about? So in NLP, that is called topic modeling. Are they talking about the diet? Are they talking about the treatment? Are they talking about the doctors? And then the second one is, what needs do patients have? What are patients seeking? Needs detection. I'm going to give you an example, later. And then, why are patients talking about certain topics? This is called dialogue act. Detection, explain information on diet, ask questions on the skin niche, sharing emotions on the treatment. Last but not least, for specific medical condition, discourse coherence is very important. Is the patient coherent? And this is particularly easy to motivate when it comes to neurological conditions and or even psychiatric conditions. So discourse coherence, we are trying to analyze is the patient's are they saying things that make sense? And I'm going to just to give you a very quick slide that this is actually some work that we did quite a number of years ago now, and we were analyzing the American Cancer Society online discussion forum. And the idea is just to run a needs detection tool to identify what do patients need. And, typically without a tool like that, it is too labor intensive and too time consuming for anybody to be monitoring a discussion forum like that. But if you have a tool, you might be able to identify, for example, physical needs. This is an example of a patient talking about their physical needs. So the patient said, I finished 6 rounds of carbotaxol and I'm slowly recovering from the assault of the treatment. Has anyone experienced joint pain after treatment? I've noticed increasing pain in both lips and recent knee pain. And I color coded the sentence in red, not because the sentence actually appears in that color in the actual post, but this is the sentence that caused the NLP tool to identify this post as the patient's looking to for a physical need. And contrast that with the right hand, with the example on the right hand side. And the patient said, I'll have 6 to 8 months of chemo. I'm so scared. I do not know what to expect. I'm having a hard time dealing with this. I'm going to attend a support meeting in April. I have a difficult time staying positive and upbeat. I've read such amazing stories on here. I hope that this board will help me as well. Hugs to all. So the red sentences is why the NLP tools would say that this patient has an emotional need. So and again, we are trying to develop tools that will allow us to classify or to put labels to some of this messages, so that maybe we could bring intervention to help the patient. Now I think I'm going to wrap up very soon, because we do want to have time to answer a few questions. I think so I talk about clinical documents and I talk about user-generated content. Actually, mental health and psychiatry is a very interesting area, because even the clinical documents themselves, psychiatric assessments, are actually highly unstructured. In a lot of medical domain, in healthcare, there's case report forms. In psychiatry, you have a form, but a lot of the time the information about the diagnosis is in free-form psychiatric assessment. And of course, there is user-generated content such as social media posts. And we have a project that we want to monitor at-risk adolescents through the instant messaging content, and we want to be able to develop a recommendation system for early intervention. Now, let me skip some of this, because I was just saying that we have developed a platform for online psychiatric analysis on Reddit posts, and this is something. This is part of a project funded by Health Canada, but I'm going to close by actually just very quickly talk about multilingual. Canada has 2 official languages, French and English. And as you know, NLP is very heavily dominated when it comes to English. And a typical question is that can we help our friends and our collaborators in Quebec, for example, where we're analyzing French. I think with the large language models in the past, 2 years, I think this is making English to a different language like French, German, Italian to be a lot easier. And the last comment that I would make is that even though we've been talking about text so far, with today's speech technology, and there's a huge amount being collected, and in many conditions, BC Children Hospital, autism, for example, kids with speech problems, there might. So we have projects where we have young kids or maybe infants learning how to talk. And in general, speech now with the transcription technology could provide a transcript very easily. So we could transcribe speech to text and then apply the NLP-based tools on text and essentially on speech. In addition to that, there are a lot of techniques where you could extract speech features from the speech data and be part of the model, so I think this is a very interesting, exciting field, and I'm going to stop, and I look forward to your questions and comments and a discussion with Leo. Thank you very much.
Thank you so much, Dr. In. We are going to have the Q&A session open. So if anyone has questions, please feel free to either just raise your hand or mute yourself or leave a comment. Yeah. In the meanwhile, we just want to let everyone know, if you want, you can follow us on our Eventbrite to not miss our next digital health seminar, or you can also, watch our past events, on our digital health learning corner.
Thank you, Dr. Ng and Dr. Celi. That was really fantastic. I think just for those who joined late or only were here for a part, I just want to kind of recap a little bit and then maybe start the question period. And as Sally said, if you have a question, feel free to raise your hand or just write it in the chat. But it was we all hear a lot about AI right now with the boom of what's happening, and I think it's really important to be reminded, as Leo, you did, in the need to consider the data that's training those models. And we live in not the perfect world, as you so succinctly put it, and most of our data reflects that. And I know that you spoke mostly in reflection of EHR data, which is structured data and has many limitations. But one of the things that I thought of as you were speaking, and then Raymond, as you brought up the fact that there's all of these additional data sources in healthcare that are unstructured and really not made use of, that might be providing a more robust picture. There is a question around what data we actually have access to right now, and whether or not that's also driving some of the bias. So I wanted to hear your opinions on that. We live in a data-rich world, but as researchers, we don't always have access to all of that. Do you think that there are better sources out there that could complement things like EHR, or are there ways to improve or reduce bias by improving our access to information that is that might include more people, if that makes sense, either through open data, or do you have any thoughts on that?
So I'll start off. To us, the only way forward is to have data sharing at the core of how we are developing the models. I think I explain it well, how complex is the data bias, the sources, the degree, and the types of bias. It's just not going to be understandable by one group of people. So to me, one group, whether it's from academia or industry, trying to build AI models, I think they're suffering from what I call AI arrogance and ignorance, because they're not going to have all the perspectives and lived experiences to understand where are the data. Like when you're looking at Reddit data, like who has the luxury of being able to post on Reddit? And are they really representing the communities that who are disproportionately marginalized? Because these people would have 3 jobs and they will not have time to go to their phones or computers to start blogging. So digitized content, internet content, it's primarily dominated by people who could scream louder. And these are the privileged individuals like us. And whatever data that you add, there is a bias in that data. And this is why we need to work more with social scientists. Like we cannot be doing this without the help of anthropologists and sociologists, because the data paints a very different picture than the real world. And it's not, as I said, what's going to happen is we're replacing a bad system with an equally bad system or even a worse system. People always push back. The perfect should not be the enemy of the good. We have AI models. It could help 80% of the population. Let's just say we're not going to help the 20%. We're not going to use AI there, but for the 80%, they should benefit from it. Well, the 80% are already at an advantage compared to the 20%. So what's going to happen is you're going to widen the divide between those who are already having better outcomes as compared to those who have poor outcomes. And unfortunately, the problems with bias it hasn't really reached most of the people. So we have here like a very, very vibrant entrepreneurial community, and we had a workshop a couple of months ago, and it's really the first time that they're hearing that, oh, there are problems with the data. So they thought that if we amass data, if we have gobs and gobs of data, they're representing every community out there, and you throw them into some encoder, and then you see what sticks in terms of what models provide the highest accuracy, then they're good to go. And as I said, there's not even an attempt to understand how did the data get there? Who does it represent? Who doesn't it represent? They said, oh, we could oversample the minority population. But the minority population who made it to your database is very different from the minority population who did not make it to the database. And when you have this sampling selection bias, the computer starts learning spurious associations, and those spurious associations are going to make it to your algorithms. So I think there is a reason why some of the experts are saying we have to slow down, because at the rate we're going, as I said, you're going to be permanently ingraining all the inequities that we see now. And I don't think that that's our intent. We have very good intentions, but there's so much that we don't know. And I cannot tell you how to fix the problem. I keep saying that I cannot fix the problem because I have actually contributed to the problem. Being part of this ivory tower academics, I've been complicit to the problems that we see now. And we need more ideas. We need people who have been historically shut out, whose voices have been muted, because I think the answers will come from them, not from us.
Yeah. And in the Canadian context, we're coming up to the National Day of Truth and Reconciliation. And I think the other thing to consider is those historically marginalized groups, there's a real lack of trust to the system. And so if you create more tools that only benefit the other groups, you're gonna reinforce that lack of trust, and then it'll get worse and worse and worse. And so we have a responsibility to those groups to listen and to learn and to be guided. We do have a question from Dr. Shivananda. Sandesh, if you want to go ahead.
Hi, Leo. I'm Sandesh. I'm a neonatologist. I work in NICU here. So talking about bias, I have a question for you. So the traditional way of when a client or user decides to adopt a practice in healthcare, you do a critical appraisal based on the studies. There is open data available. A lot of people talk about it and then make a decision based on feasibility that you would adopt it. Whereas with AI models and how quickly these are put into practice, or at least given out in a tested environment, as a clinician, I fail to understand how do I critically appraise this has gone through the tests of period, it's not going to cause any more problem, or should I just be following? Eventually, when 4 out of 5 hospitals start adopting, maybe it's time for me to use it. That means I'm making decision not by knowing the true principles, but waiting for experts to tell me. Do you have a way in which individuals can start learning about it so that they can start applying their existing knowledge to critically appraisal some of these AI model-based interventions when they're marketed to us, either as using an app or making clinical decisions at bedside?
So historically, and I don't know if this is intentional or not, we do not have the data science skills. And as I said, the medical knowledge system is very tightly controlled by a few who are the methodolaries. So they are the only ones who understand how to come up with guidelines. And the rest of us, we just follow what the professional societies are feeding us. And we know that these are all laced with conflicts of interest. But the thing is, we don't have the capability to truly take a look at the data. And to me, data science has to be at the core competence of becoming a clinician, because your chances of being misinformed or disinformed is higher if you don't understand how to analyze the data. And then the next question is, how do you train clinicians to be more data science savvy? And our answer to that is the way to teach this field, which is very, very rapidly evolving, is to teach them how to work with data scientists and social scientists. Because data science is truly a team science. There's no such thing as expertise. There's only collective expertise. And if our goal is to learn from each other, learn together, teach each other what you can teach others, then, and this is going back to my last slide, this is how we do things. This is how we work together. That has to fundamentally change, because if you don't change that, we're just going to be repeating all our mistakes in the past. We're just going to be rearranging the furniture of the Titanic. But somehow we need to change the course of the Titanic and not just put band-aids in the leaks. It's easier said than done, of course. And what I'm hoping is a lot of you will get excited and would start thinking about potential solutions and would start engaging people who have not been brought in the past. And I credit AI for putting a magnifying lens. We've had the health disparities forever, but for the first time, it's a sexy problem. It became a machine learning problem. And we have other people weighing in who don't think like us. And I'm truly excited. I think we're at the crossroads, and finally, we're gonna make some headway with how to fix the problems that have been here decades, generations after generations. But I don't have the solutions right now. And I keep saying that I cannot be part of that group that is prescribing what needs to be done, because that prescription should come from a much bigger table, bringing in the voices of the patients who have suffered the most compared to us.
Thank you so much. Appreciate your answers.
Yeah, I appreciate the ending on the positive, and I think talking about bringing in the patient voice, I do really appreciate what you're doing, Dr. Ng, and trying to leverage this technology to do just that and to understand your patient population better, with the caveat, like understanding that not all patients are accessing these blogs and things like that. So there are some limitations, but it's a really novel and unique application of the technology to do some good. And I think there's a lot of opportunity there still. Cindy, do you want to, let's ask a question?
Yes, thank you, Dr. Ping. So the question is directing to Dr. Ng. Thank you so much for the talk, and Leo as well. So I have a question regarding the data type that you're dealing with. Since it's patient confidential, as well as you are dealing with your results can directly impact patient outcomes, right? So I understand you mentioned that you are working in collaboration with clinicians as well to make sure the accuracy and ensure patient safety. But would you think it will be a valuable addition if a clinicians with some computational background can join your team? Like, what would be an ideal candidate as an NLP practitioner in healthcare?
Yeah, so thank you for your question. And in fact, the first question that Beth asked when she was asking about data access, I was about to say that in the health domain, data privacy is extremely important. And this is not, and then we were talking about, mental health. I mean, this is even more important because there's a lot of stigma that could actually go into it. And so all the projects that we have, we're actually working with the ministry and PHSA, and so there is that safeguard, to it. And so there's absolutely no question that a lot. I mean, I mentioned in the chat that we actually have clinicians that co-design and co-manage the projects from the very beginning, and I completely agree with Leo. It is such an interdisciplinary work, and in fact, the nature of data science really require the data scientists to be really embedded in the application, because you actually need to understand the data, and then you also bring up the point of how to interpret the results and how to deploy the results. So, the data scientist's job is to, deal with the data, build the models and, build the tools, how to use, what is the policy of using it, how to approve it. Those are much bigger questions. And so that needs to be fully embedded, and we need the medical community to be fully engaged when it comes to deployment. So our job is basically saying that, so okay, we could do this. This is the accuracy that we have, and it may also come with a list of restrictions. Like Leo was saying that maybe one of the restrictions is that we don't have indigenous data in the training set. Just like you have drugs, and so I mean, drugs has an intended use, and FDA would want you to do that. So I think that is our job, to actually curate all those things and make that known to the health professionals, and the decisions will be made by them.
Thank you.
Thank you.
We have a bunch of messages of thanks, but we are at time. And so I just want to echo the comments on the chat again. Thank you both so much. It's an incredibly important and nuanced conversation. And I really appreciate you coming here to join our institutions and present this, so we can keep talking about it and keep building our knowledge. Thank you. Thank you both.